Greetings from Manipal University from Karnataka State. My topic for today is evolution of ovarian hyperstimulation syndrome over decades, briefly called as OHSS. We all know it's an iatrogenic cause because of controlled ovarian stimulation, and it happens very less these days, but long back it was quite a bit number. The incidence of moderate to severe OHSS is between 3 to 8% in IVF cycles, but sometimes it can be as 20%. But this is an old story. That's how the evolution was, that the dreaded complication of ovarian hyperstimulation syndrome has been reduced by understanding the proper knowledge of pathophysiology of ovarian hyperstimulation syndrome, how to diagnose and manage effectively to reduce complications. So we long back knew that in a normal cycle, only one ovum is released, but in an IVF cycle, we need a lot more. So this was not understood as to how to control this ovarian control stimulation. Ovarian stimulation, hence, is now called as controlled ovarian stimulation. By manipulating the hormones, we now know over the years we can reduce ovarian hyperstimulation syndrome. Now, this should never happen. A large ovary like this with free fluid, I think it's a complication by itself. So when we know the cause, we have over the years, this is one of the evolution. We understood that HCG, human chorionic gonadotrophin, is the culprit of ovarian stimulation, which is excess, all because it increases vascular endothelial growth factor, and that itself causes fluid permeation into all kinds of spaces like hydrothorax, ascites, and anasaka sometimes. So VEGF is released because of this HCG itself. So we have understood over the years that granulosa cells stimulated by HCG will cause increased vascular endothelial growth factor and more of it over the time. Now this VEGF basically goes and kind of stops certain things in that vessel there, and thereby the pores are released or opened up. So the intravascular space goes into the extravascular space, and thereby it causes ascites. So we know that ascites is the cause of the pores getting opened up in the vessel, and finally we know that VEGF is the problem. So exposure of ovaries to HCG, LH basically, following controlled stimulation by FSH underlies most cases of OHSS. That's the cause. Exposure of hyperstimulated ovaries to HCG leads to the production of pro-inflammatory mediators and other cytokines. This results in vasoactive mediators released basically from that hyperstimulated ovary. And I mentioned that capillary permeability is increased, which causes the extravasation of fluid from the intravascular component into the third space. The hemoconcentration, which ensures results in these kind of patients, will cause hypercoagulability. You can understand when the intravascular space goes out, the hematocrit will increase, there will be hemoconcentration, and this will reduce organ perfusion. This is another evolution we understood over the years. The pathophysiology of OHSS is hemoconcentration, apart from several other problems. Now, we also over the years realized that there is activation of intra-ovarian renin-angiotensin system, RAS. HCG causes a strong activation of this RAS and regulates vascular permeability, angiogenesis, endothelial proliferation, and prostaglandin release. With increasing VEGF, there is a potentiation of or increasing the ovarian hyperstimulation syndrome. So this is a simple diagram to say that early OHSS, late OHSS, whatever happens, hyperstimulated ovary will cause increased intra-ovarian RAS activation, and this will act on the blood vessel and thereby increase capillary leakage. So this is another evolution over the years. We understood why there is leak from the intravascular space to the extravascular space. So once again, vascular permeability, reduction in colloid osmotic gradient favoring leakage to the extravascular space, the third space loss will be depletion of intravascular volume. The loss into the third space basically will cause intravascular volume and also hypotension finally. Ascites, hydrothorax, thrombosis, urinary output decrease, renal failure. So please understand, over the years we have realized that thrombosis is all because of hemoconcentration, and there is thrombosis, hemoconcentration, thromboembolism, renal failure, and so on. So the VEGF, HCG VEGF is a culprit of leak from the intravascular to the extravascular space, thereby increasing hematocrit. So the early OHS is within 9 days of HCG, and the late OHS is after that. Usually late OHS is concerned with the implantation. It's just because of the implantation of the embryo, they can have late ovarian stimulation. Now, if you look at this diagram, you'll realize number 1, 2, 3 for the fourth line. The ovarian stimulation will cause increasing intravascular to extravascular, thereby increasing hematocrit. The PCV, if PCV packed cell volume on hematocrit is more than 45, it is an alarming sign. If the total count is more than 15,000 because of concentration is once again alarming, because these will cause thrombosis. So WBC and PCV are the main areas to be concentrated upon. So over the time, it's another evolution. We understood the pathophysiology, investigation, just concentrate on hematocrit and the WBC, thereby causing a good interventional therapy to reduce the problem. So once you know there is WBC rising trend, we should start heparin. More than 15,000 heparin must be started. Hematocrit more than 45. Please understand, you have to either give some kind of a treatment to reduce that, but never give diuretics. Do not give diuretics just because there's oliguria. It will cause more concentration and more problems. So we have to predict ovarian hyperstimulation syndrome. We divide the patients at risk in primary risk factor like young age, low BMI, polycystic ovarian itself, PCOS itself, and the previous history of OHSS, increase anti-Mullerian hormone, and increase antral follicular count. The secondary risk factors are rapidly rising E2 levels and a large number of developing follicles in the middle halfway through. And if it's more than 14 follicles of 11 millimeters, we do get worried. And large number of USAT recovered once again get worried. Hence, to prevent ovarian hyperstimulation syndrome, the primary prevention is to understand the pathophysiology itself, as I mentioned, choose the lower risk treatment options, and identify secondarily the response itself halfway through and even finally. And tertiary prevention is diagnosis early and manage appropriately. So targeting the right number of follicles, individualizing IVF treatment according to the AMH antral follicular count, avoiding HCG. That's another evolution. We avoid HCG if you suspect estrogen is very high, number of follicles are high. You give leuprolide. Leuprolide can be given 1 milligram and then pick up 36 hours later. You get very good oocytes. Though the number may be less, the maturity may be less, you just definitely avoid OHSS. So the evolution of OHSS is understand, don't give HCG, but give leuprolide 1 milligram. That will prevent ovarian hyperstimulation syndrome. Consider alternatives like leuprolide, as I mentioned. Coasting doesn't really work well. You postpone the HCG by 2-3 days, you'll find all the follicles shrink, and I don't think it really does well in practice. We can give antagonists because when you give antagonists, you're antagonizing the LH. If you are given HCG and then there's OHSS, you can give in the luteal phase antagonist 0.25 of cetrotide or orgalutron or anything what you get here. And of course, we don't transfer the embryos. We will cryopreserve, and you can definitely sometimes cancel the cycle also. So we now know that AMH seems to be one of the important finding. Usually above, the normal values are between 1.5 to 3.5, but sometimes above 3.5, say 4.5, 5.5, 7 is a direct risk. Higher the AMH is a direct risk of ovarian stimulation syndrome. So I feel above 5.5 itself is alarming, and 7 is definitely a direct risk for the same. So antral follicular count, usually 8 to 10 antral follicles are seen in each ovary. If you find more than 14 to 15 in each ovary, once again you suspect the response is going to be larger than what you expect. So the simple treatment is to give dopamine agonist. Dopamine agonist is the cabergoline. You give dopamine agonist and it will stop the VEGF. The dosage is 0.5 milligram once a day for about 7 days. So I would give antagonist 0.25 for 7 days. 7 days of cabergoline, and I think most of them are doing well. If you find the hematocrit is going up, you can give starch, which is a controversial subject, but you can give something like intravascular component like starch or something else like the albumin, which is not very much advised because of the other problems. So give dopamine and things will be fine. But we remember, if you have given leuprolide, they don't need anything else after that. Most of the time they are fine, but you still have to do a hematocrit about 2-3 days later. That's the difference now. Evolution over the years, we have realized if you're given leuprolide, there is most of the time no need to give antagonists, cabergoline. You simply monitor them and they don't get into OHSS. That's the biggest evolution over the time. Cabergoline prevents excessive increase of VEGF. It basically stops the area what I told you, and the treatment is 0.5 milligram for about 8 days or 7 days, it doesn't matter, because it acts on the anti-angiogenesis property of itself. The colloid infusion are administered around the time of oocyte retrieval, prevents OHSS by binding to and deactivating the vasoactive mediators of OHSS, is definitely a concern because anaphylactic reaction, possible transmission of viral infections, and of course prion disease did not reduce the severity over the studies we found and significantly reduces pregnancy rates. So it is really not very advisable if you're transferring the embryos, but you can do all this, but don't transfer the embryos. Things are fine. But in my clinical practice, I'm finding hydroxyethyl starch seems to be the cheaper one. It's a plasma expander, alternative to albumin, non-biological, therefore negates the basically albumin use itself. The Cochrane review by Youssef et al. Noted that there was a statistically significant decrease in ovarian hyperstimulation syndrome, and I think it's a simpler method to, when the hematocrit is 45, I think we can give 1 per day or 2 per day, bring down the hematocrit, do all the other things like what I said about antagonists and cabergoline, they don't get into problems. So vasopressin-induced VEGF secretion blockade is another research which is coming up. So over the evolution time, I always feel the next 5 years we'll understand something more on relcovaptan. So vasopressin V1A receptor antagonist. It inhibits VEGF by modulating vasoconstriction and the vascular proliferation as such. It is still under the research, so we do not have experience in this relcovaptan. This is a vasopressin-induced VEGF secretion blockade. I have published this data in 2015 just to emphasize that hematocrit is a simple method to predict and manage ovarian hyperstimulation syndrome in assisted reproductive technology. The Journal of Human Reproductive Sciences, I think it's a very quoted by many people also, and I'm glad that people are using this simple technique of hematocrit observation. So, antagonist administration in women with established as OHSS, dopamine agonists may have beneficial role in the treatment of established ovarian hyperstimulation syndrome. The fluid balance has to be done by the oral route, guided by thirst, and you can go on monitoring the system as well. Women with persistent hemoconcentration, despite volume replacement, and with intravenous colitis may need invasive monitoring, which should not happen in clinical practice, but just avoid diuretics as they further deplete intravascular volume. How should the risk of thrombosis be managed? The severe or critical OHSS should receive low molecular weight heparin if the blood counts are more than 15,000. The duration of LMWH prophylaxis should be individualized. I would give for about 7 days and stop it. So, indication for surgical management only if there is coincident problems such as adnexal torsion, ovarian rupture, or ectopic pregnancy. So, to summarize, the pathogenesis of OHSS, HCG is the main culprit. Hyperstimulated ovaries will cause, of course, increased vascular endothelial growth factor, increased capillary permeability, vascular component shift from intravascular to extravascular space, hypovolemia, low renal perfusion, high hemoconcentration, increased ovarian volume, and ascites and edema. So ultimately, hemoconcentration seems to be the main area of focus in ovarian hyperstimulation syndrome. So the age is definitely a risk factor. The lower the risk has higher chances, and higher the risk has less chances. And I think over the years we realized we have given up the crystal ball. We can predict actually all the time who will get pregnant OHSS, how do we treat, and over the years I think we have given up this kind of forecast. We can actually forecast scientifically and say that how do we prevent OHSS and how do we treat to save lives of women with controlled ovarian stimulation. To summarize, OHSS is iatrogenic but preventable. HCG is the culprit. Identification of the high-risk woman. Packed cell volume of the hematocrit should be low, ideally less than 30. Antagonist protocol is reassuring. So we have again over the evolution of the OHSS, we were doing GNR, the channel log long protocol. We have given up most of the time. We just do the antagonist protocol. Agonist trigger like the leuprolide or any of those can be given. And HCG small dose also can be given, but I don't give because that itself can cause problem. So only give agonist, and diuretics must be avoided. And severe or critical OHSS must receive low molecular weight heparin prophylaxis. Thank you very much.